Hello, and welcome to part 4 of chapter 11 on the lungs. We have just finished part 3 with gas exchange, and I'll remind you there are the 3 aspects of respiration. There's ventilation, there's gas exchange, and there's perfusion, and that's where we are moving next. So with perfusion, one of the problems that we're going to see is something called pulmonary hypertension. And the pulmonary hypertension can lead to right-sided heart failure. So let's review a little bit about the anatomy. The blood that comes to the lungs comes from the right side of the heart. That is all of the blood that's leaving the right side of the heart. It's going to go out to the sides and be right back. Usually, the pulmonary vascular pressures are really low. That's the explanation for why the right side of the heart has those much thinner walls. The right ventricle is much, much thinner than the left ventricle. But when somebody has a chronic lung disease, the oxygen levels in the alveoli keep going down. And as we saw, that was a great mechanism when this hypoxic vasoconstriction is a great mechanism for having a ventilation perfusion match. But if all of the alveoli have low oxygen, you may be able to predict what the problem is going to be. These images are once again from that video that's on our additional resources, and I highly recommend it. So let's see. Hypoxic vasoconstriction produces generalized increase in blood pressure, the pulmonary hypertension. So let me remind you, we have these 3 alveoli. Maybe there's some limited, for some reason, we've got some regional hypoxia. And what's supposed to happen happens. If we have less ventilation happening here, then those arterioles that service this alveolus or other alveoli like it, they kind of close down or increase the pressure. And so less blood goes through them and more blood goes through these other arterioles. And as the pulmonary disease progresses, we have more and more and more areas where the alveoli don't have good oxygenation. And so we end up with this this hypoxic vasoconstriction in more and more of the arterioles. And ultimately, as you can imagine, when the person's overall lung fields are affected, we've got the hypoxic vasoconstriction happening all over the lungs. That's going to jack up the pressure in those vessels. And where did that blood come from? The right side of the heart. So the right side of the heart now, all of a sudden with its thin ventricle and everything, it has to beat so hard to push the blood through. And so it gets stronger and stronger over time, which sounds like a great thing. But again, when those ventricle walls get thicker, that means there's less space in the middle for blood to fill. Or if the heart doesn't get stronger, if the pressure comes up too fast, too high, too fast, that can lead to dilation of the heart so that the actin and the myosin aren't overlapping very much. And so that makes the heart less able to pump against all this pressure. So either way, if we get failure of the right ventricle as a result of a pulmonary problem, this is referred to as cor pulmonale. This is from the Latin cor, heart, and pulmonale, the pulmonary. So it's right heart failure due to a lung disease. What does that look like? Well, we said right side of the heart is pumping really hard, but it can't push hard enough against the pressure from the lungs, from the blood vessels in the lungs. And let's see, we're going to get back up of the blood from the right ventricle. It's going to back up into the right atrium. That blood, where did that come from? That came from the 2 vena cavae that are bringing blood back from the rest of the body, the deoxygenated blood. So we're going to have pressure increasing in those blood vessels. So going back into the systemic veins, And so the consequences we're going to see are peripheral edema, that pressure is going to keep backing up from the vein back up into the capillaries. That's going to have more pressure pushing the blood out of the capillaries and less pulling it back in. And that's most obvious in the legs. It'll happen all over the body, but it's most obvious in the legs, the dependent regions. And the other place where it's really obvious is, remember here, the blood that's being drained from the head, that's going to go towards the superior vena cava. It comes through the jugular veins. Well, if the pressure's real high in the jugular veins, they're going to stick out a little bit more. So that's an area where you may be able to detect this just, visually in assessing your patient. You'll see jugular vein distension. Cor pulmonale, right-sided heart failure due to lung disease. Let's talk about another problem that happens with perfusion. This is pulmonary embolism. We've all heard of them. And if you're like me, I had a devil of a time picturing this. I could not make the connection between the legs and the heart. And with the legs and the lung. And so we're gonna walk through that. So what generally happens is, for some reason we have, remember Virchow's triad, patients in a hypercoagulable state. We've got some circulatory stasis. They're in bed after surgery. They don't want to get up. And the blood pools and starts clotting. So we've got a big old clot in a leg vein, and then a piece of that breaks off. Here's the thing. When you're in a vein, this is just a cartoon of the circulatory system down. The lower part represents systemic circulation, and the upper part represents pulmonary circulation. And here's the heart in the middle. If we've got systemic veins, we're down in the legs, and we have a clot. When that clot breaks free, the vessels that it travels through on its way to the heart are getting bigger and bigger and bigger. So there's nothing that's going to catch that clot. That clot started out in a vein down here, and it's not a super small vein, but let's call it a small vein, so we can have this image of a smaller thrombus. And it's like it's going to go through these big honking veins as they come together to form the inferior vena cava. That's going to come through in the simplified diagram. That's going to come through the right atrium, deoxygenated blood, right? It's coming back to the right side of the heart. That's going to go through the right ventricle. Now we're going to go out through the pulmonary arteries. Now the vessels are going to start getting smaller and smaller and smaller as they branch. And that is where the clot is going to lodge. So although it was formed in a leg, because of the pathway that it has to take, it makes sense that the next place it's going to get to a vessel small enough to catch it, it's going to be in the lungs. So the thrombi break off, travel up the vena cava through the right side of the heart, and then as the arteries branch and you get to a small enough spot, that's where the clot's going to catch. And so that's going to impair blood flow to the lungs. If it's a small clot, it may impair blood flow to a very small part of the lungs. Or if it's a very large clot, it's going to impair blood flow to a larger area. So that's what this lower part says, various degrees of pulmonary embolism. So if you have multiple tiny, small emboli, this may resolve on its own. If you have a blocked lung region with no perfusion, so the patient still respires, it's still breathing, they're still getting ventilation, there's air coming into those alveoli, but there's no blood flow going by those alveoli, so you're not picking up any more oxygen. So it's dead space or wasted ventilation because you can't get gas exchange. And then the absolute worst case, if you have a very large embolus, so-called saddle embolus, and it's called that because when it comes out, let's see that we're coming out here from the right ventricle, then the pulmonary artery branches, and this clot may be so big that it blocks both sides. There's almost no chance of that that patient surviving that, because it can be immediately fatal. The right side of the heart keeps pumping, trying to pump, but it can't push anything past that blockage. So the pressure is going to go way up, and then there's no blood going through here. So there's no blood returning to the left side of the heart, which means the rest of this is out of luck. And so the person dies of hypotensive shock. So this can be, this can be fatal. This is why we work so hard to avoid having our patients develop these blood clots, why we want them up and out of bed, why we give them anticoagulants, why we squeeze, massage their legs. We want the blood to flow. Okay. Let's continue. Another topic, it's still related to this as well, gas exchange. So a moment ago, we just talked about how the pulmonary problem, lung disease, can lead to failure of the right side of the heart. Now we're going to talk about what happens if it goes the other way, if the left side of the heart has a problem, if left heart failure, and how that backs up and has consequences in the lungs. So just as in systemic circulation, when we said that when the pressure was really high, we're going to get more fluid to leave the capillaries and less of it is going to come back in, and we end up with edema. So when we have low pressure, we have low capillary hydrostatic pressure, that's going to inhibit edema. And any fluid that comes out of the capillaries and stays out of the capillaries can just get picked up by the lung lymphatics, and it just drains the extra fluid, no big deal. But edema can happen in the lungs, and the most common causes of this are, as I mentioned, left-sided heart failure. So the left side, that's the side left. This is the left. That's left, the thorax. That's the blood that's going to come out the aorta and go supply the rest of the body. When there's very high systemic blood pressure, and that left side of the heart has to work against that high blood pressure all the time, that left side of the heart can fail. It doesn't stop beating altogether, but it just can't beat enough against all this pressure from that's in the aorta. And so that blood backs up from the left ventricle, backs up through the left atrium. Where did the blood that came to the left atrium come from? It's newly oxygenated blood from the lungs. And so that pressure is going to back up into the vessels going into the lungs. So pressures back up through the left atrium, and into the pulmonary arteries and the capillaries. And so that's how we're going to end up with pulmonary edema as a result of left-sided heart failure. We may also get pulmonary edema due to increased capillary permeability that can occur due to acute respiratory distress syndrome. And that's what's going to be covered on the next slide. And this is, if I'm not mistaken, our final slide. All right, so what happens in ARDS? There is some kind of lung insult due to sepsis. It could be pneumonia. There could be trauma, a physical trauma can set this off. But basically, we have the innate side of the immune system activated. So the macrophages and neutrophils are activated. Over on the left, this is a close-up of a single alveolus, and over on the left is the normal condition. We have, let's see, there's a space where the air can be. We have fluid on the surface of the cells that line this alveolus. That's the surfactant layer. We have a couple of different kinds of alveolar epithelial cells. There's a capillary that comes along the alveolus for gas exchange. And there's some immune cells. There's a macrophage station there, neutrophils, rolling by, and that's normal. When there has been an insult and the macrophages and the neutrophils get activated. They release inflammatory mediators that can actually damage the epithelial cells. So if you can see on this side, the ARDS side, there's damage to these epithelial cells. And that damage is going to allow more fluid to pass into the alveolus. At the same time, remember the inflammatory mediators, that's going to cause vasodilation and it's going to cause leaky capillaries. So more of the fluid is going to come out here. This is edema. So there's more fluid coming out here. That's going to increase how much space we would have to pass across. And on top of that, we can't even get air in here because it's full of fluid, and it's full of fluid that's rich in protein. So it's hard to get rid of this fluid. This is bad news when this happens. So let's see, where are we? Increased capillary permeability, the edema builds up in this space, and then it can flood into the alveolus because the cells that would ordinarily be here and keeping fluid out, they're not there anymore. And so this fluid can just pass in here. We lose surfactant because we don't have the type 2 cells to make the surfactant for us anymore. It brings in protein-rich fluids, and this is going to impair gas exchange, of course. Lung compliance decreases and have a difficult time inflating any of the alveoli. So in these cases, the highest priority is trying to get the infection down, manage this immune response as well. And some patients who have an over-the-top immune response, this is especially work. So two patients can have exactly the same infection, and one of them ends up in acute respiratory distress syndrome and another one doesn't. And we don't understand exactly why it happens, except that we say the neutrophils and the macrophages are overactive. They're producing too many inflammatory mediators, and they're creating all this havoc. And so that's why in some cases, suppressing the immune system, although it sounds counterintuitive, but suppressing the immune system actually seems to be helping some patients. Okay, and that is all we have time for on the respiratory system. So that is the end of chapter 11.